Here on the medicine couch, I really tried to help PAs and NPs figure out where they fit in medicine. Part of the way I do that is by interviewing APPs that work in the various medical specialties. Today I'm joined by a PA, David J. Bunnell, and he is going to tell us about his experiences working in electrophysiology and all the ins and outs of that specialty. I just want to say a quick thank you to all of those who subscribed after my last video, where I put out the plea to help me reach 500 subscribers by my birthday on June 17th. If you haven't subscribed yet and you like this channel, please hit that little subscribe button down below.
Hi, I'm Dave Bunnell, and I'm the Associate Program Director at Frostburg State University PA program, and I have clinical experience in cardiac electrophysiology and cardiothoracic surgery.
Welcome, Dave. Thanks for joining us on the channel today.
Oh, it's so great to be here. Thank you for asking.
Let's dive in and talk a little bit about electrophysiology. I feel like it's one of those specialties that doesn't get mentioned that often. Are there many APPs that work in electrophysiology?
EP is getting very big, very fast. It's really the connection between complex physiology and complex technology. And as more and more people get devices, there's a need for people in this field.
So tell us a little bit about your path since graduation. I'm always curious about how people find their way into a specialty.
Absolutely. So I did a rotation in cardiothoracic surgery and surgical critical care. So that was my start. And then we came back to Washington, D.C., where I spent some time at Washington Hospital Center Surgical Critical Care. And then I was at the Washington, D.C. VA Medical Center in cardiothoracic surgery for a number of years. And it was about 2014 that I transitioned into cardiac electrophysiology. My joke is that I was a plumber for a long time, where I got flow going again, and then I became an electrician.
So, for those who may not really be familiar with electrophysiology as a specialty, what exactly does the specialty entail? Like, what kind of cases are you seeing?
Any given day, it falls into one of three buckets. It's either heart rhythm problems or arrhythmias, cardiac devices, or scary symptoms that might be heart problems. So a lot of people are feeling crummy and people fear it might be an arrhythmia, so they come to us to sort that out.
So, are you placing things like Holter monitors and Zeo patches and things like that, trying to determine what the rhythms are, and then determining what implantable device, if any, might be the right choice for a patient?
Certainly, if we're spending time in the bucket of scary symptoms, you do spend a lot of time trying to catch it. A gift is if you actually have caught it in some way, shape, or form, either on a 12 lead ECG or on some other ECG, maybe if you're in the hospital. So if you have scary symptoms and we're chasing it down, Holter monitors are good for 24, maybe 72 hours if you have that. There are the glorified Band-Aids that are heart rhythm monitors. The brand name that is most common is Zeo Patch, of course, and that lives there for 14 days. Is also an event monitor where you press a button if you feel something. And then, of course, the next level is an implantable loop recorder, where it's a small device, very thin, smaller than a AAA battery, that slips under the skin and depending on the battery, can live there for about 2 or 3 years.
So, tell us a little bit more about the scary symptoms bucket.
There are some people that they feel bad and they don't know why they feel bad. And the problem is, if it's an arrhythmia, you might feel bad for something that's on and off very quickly and very difficult to catch. Matter of fact, after some time, patients can begin to think maybe it's in their head, and maybe even people around them might think it's in their head. And I can tell you they are so relieved to find out it's a heart rhythm problem and it was just so hard to catch. And it's even better to find out it's a heart rhythm problem that we might be able to take you to the electrophysiology lab to ablate, where we put catheters in and make it go away. That's a pretty common story, but it's also sadly common for people to walk around with symptoms. That's one scary symptom where I feel dizzy. Then there's a whole other group of scary symptoms where people experience syncope. And that can have a number of things involved, either an arrhythmia or neurocardiogenic syncope that we work up. But the way I approach that in many ways is to talk to people to say there are many things that might be causing this. And some of them are scary and some of them not so scary. So we're going to go through the checklist and start to rule out the scary ones and find it. And if it took a while to find, it might take us a while to sort it out. But if they have patience, so do we, and we'll find it.
When you're working electrophysiology, are APPs mostly in an outpatient clinic, or do you also spend time in the hospital in the EP lab, or is it kind of a mixture of both?
So different practices work with PAs in different ways. I had the benefit of being in my happy place, which is everywhere. I was first called for consults within the facility. We were a tertiary care facility within the VA system, so people knew my phone number as well as my physician colleagues. So we were answering questions outside. We had ablations that we were doing or devices. In addition to that, we worked with a cardiac device monitoring center. So we actually monitored every pacemaker east of the Mississippi River. So I backed up that team. The good news is that PAs can fit everywhere. And so, no matter what paradigm a particular practice has, the answer is that there's a room for a PA. And another good point is that PAs are not generic, right? We all come with our own training and experience. Therefore, if somebody came like me with surgical hands and very comfortable in a surgical setting, of course the lab is fine. There are some people that are uncomfortable there and really came from an outpatient setting before. I know some people that just do one or the other. So the answer is it really depends on your practice and the size of it, because there are some practices that are very, very big. And
Mhm.
as a result, there is a need to have someone always doing a thing. Like a good example is there's a practice within the District of Columbia that I'm aware of that they employ a lot of nurse practitioners and they spend all their days doing devices in clinic.
Mm.
So while I did a little bit of everything everywhere, the nature of their practice is they needed people in the clinic.
Yeah, that was gonna be a question I asked is if you encountered very many nurse practitioners in electrophysiology, but it sounds like there are a pretty good mix of both.
There's a good mix, but there are many more nurses and nurse practitioners, at least in my anecdotal experience, because all practices are getting more and more devices and they have these device clinics. One of the common paradigms is to have nurses, RNs in those places. And many of those RNs went on to get their nurse practitioner degree. There are PAs. I really think that it's a great opportunity for PAs that's undervalued. And
Yeah,
it becomes a paradigm within the specialty, right? So if you haven't thought about a PA, maybe you haven't done the math on what, maybe you just didn't have an experience where I was there was experience.
right.
What I can say is the specialty of electrophysiology, more than others in my experience, is very accepting of PAs and NPs, to the point that anybody going in this direction should definitely join the Heart Rhythm Society for the education and the connection in the community. And I'm here to say that there are a lot of people that are PAs and NPs that really have contributed in significant ways and not as second class citizens. I really feel like that they're embraced in that community, and it's an amazingly small community when you consider the amount of people that have arrhythmias and devices. It's shocking how few electrophysiologists there are to serve the country.
Going back to kind of electrophysiology and what APPs actually do in this specialty, are there procedures that PAs and NPs do, or are you mostly the detective and then the physicians will do all of the procedures and putting in devices?
So there are some people that come to you with known arrhythmias, and maybe you're helping them manage their medications with antiarrhythmics, and that's a piece of it. And there's a specific arrhythmia clinic for that story. There are people that have devices, and actually, there's something really special about people who have implantable cardiac devices, is that they now have a relationship with their EP team for life. So those are different kinds of clinics. Day to day, I'm answering consults. I'm seeing patients we've seen. We have an electrophysiology lab where we're doing things like doing ablations for atrial flutter, atrial fibrillation, AV nodal reentrant tachycardia, ventricular tachycardia. So that's where you put a catheter inside somebody's heart and you map it to find out where the arrhythmia is. And if we map it appropriately, we can then put the catheter in and kind of buzz or burn a very small piece of tissue and make it stop. And that's one piece. Another piece that you do are you place pacemakers. And people understand a pacemaker is a pulse generator in the skin with two wires that go into the atrium and the ventricle. However, we also place implantable cardiac defibrillators, people with heart problems, where it's watching you all the time. It's kind of a paramedic in your chest that gives you a shock if you need it. But then there's people that have defibrillators, but heart failure as well. And those are biventricular ICDs. Think about somebody with a left bundle branch block where maybe the right and left bundle are not synchronized well. Well, when you have a very low ejection fraction and that the width of that left bundle branch is really wide, some people really are helped and really can be bumped up a New York Heart Failure Class Association by this device. So there are some people you can get a heart failure as well. There are also some heart failure devices that's monitoring. You can put a pulmonary artery pressure monitor in somebody, and we've done that a fair amount. And I guess the new and exciting thing out in the world, and maybe it's not as new as it was, are small pacemakers that are completely intracardiac. So instead of having a device, you have something about the third of a size, a AAA battery, and it goes in your ventricle. First, it was only for ventricular issues. So if somebody had a VVI pacemaker or something like that. But now they have motion sensors in it, so it feels the atrium rock. So then it can time with the atrium.
Oh,
So
wow.
really amazing things. The technology in EP is astounding. So if you like computers, if you like figuring out the computer, it was not uncommon for me to program pacemakers and defibrillators. That's one thing is programming. Another is interrogating it, because not only could it pace your heart or defibrillate you, it also knows what it's seen. So sometimes you can go in and talk to the little computer in your chest and ask what it's seen, and you
Oh.
can really provide some great diagnostics through that as well.
Yeah, I was just thinking when you were talking about that, this is a great specialty for a marriage of people who like technology in the human body. So when you were talking about all of these procedures, the ablations and the catheters and all those things, is the APP doing any of those? Are they assisting, or is that all the physician?
So it depends on, again, depends on the service you're with, because there are so many ways to be successful as a PA or NPA in these worlds. I can tell you that when I came in with surgical hands, I frequently assisted at the table, placing catheters, being a part of the placing of pacemakers and defibrillators. But at the same time, if there was an electrophysiology fellow, which there currently was, happy to give them experience, because not only is there what's happening at the table, think about all the electronics that is going on. And actually, there's a side table with all the computers that are reading everything that's there. So, in addition to be able to see it and manage those computers, there's also very kind of high tech pacemakers that help enable you to do your ablations. So if it was just a day where there was an EP fellow, I was happy to man the computers and make that happen, because you could create arrhythmias. A good example is AV nodal range tachycardia frequently starts with a premature beat, either atrial or ventricular. So if you're trying to make that happen, you have to set up the pacer in a certain way to precipitate that. So that's certainly where I was as well. So I really was valued and felt value by my ability to really fill any role. I've always said throughout my career, you got to be ready to lead, follow, or get out of the way at any given moment. And the trick is to know when that right moment is.
As the technology grows and we learn more about what we can do to help people, I assume that this is just going to be a specialty that is going to have major advancements and major growth.
Yeah, I think with an aging population that this is definitely a growth industry. I think on top of that, I think there's a better understanding of the arrhythmias and how to find them. I've never seen an electrophysiology practice that has difficulty finding patients. So knowing that there are very few electrophysiologists in the country, that tells me that there are people that really are underserved. And I think that there really is something to having an electrophysiology eye for an EKG. A good example is that I came up as a paramedic. So I spent more than a decade there. I spent more than a decade in cardiothoracic surgery and reading EKGs, teaching EKGs during all those times. But it really wasn't until I spent 7 years going to an EKG conference that I really started to see it in ways that I had never seen an EKG before. And I really think that there is really something to an electrophysiologist's eye. And the best that I can tell that comes from that is all the hours you spend in an EPA lab with catheters inside someone.
Obviously, having experience reading EKGs and getting as familiar as you can with basic cardiology conditions are obviously helpful, but do you feel that people need to be a bit of an expert to move into it?
No, I think it's a brilliant question because we can go ahead and get rid of the imposter syndrome, right? Something people feel commonly. I think that there is no specialty that can't be learned. There's no specialty that you can't come to from your understanding. Now, I also believe that you need to take an active role in it. But the fact that you were good enough and smart enough to get through PA school, pass your pants, and practice, therefore, you're good enough to start anywhere. Now, that doesn't give you keys to the kingdom as an expert yet. That comes with really hard work and collaboration and insight. But the answer is with anything, I really think, is you start where you are and you go from there. And yes, EKGs can be learned, and there are so many resources out there to learn it and understand it and find your way. And if you think that maybe pacemakers and defibrillators are complicated, well, I'm here to say that there are several companies. So not only do you have to learn the pacemaker, you have to learn the other company's pacemakers, and you have to learn several generations of pacemakers.
Yeah,
None of that happens overnight.
right.
All of it happens with intentional and thoughtful work. And my advice to anybody coming into the specialty is that the people you come to work with need to know where you're at, and to be able to have a conversation is, here is my understanding now. And someday I really hope to be an EP ninja, but I'm not today. And I want to work with you to do that. And if there is somebody genuinely on the other side of that conversation that says, I think we can work with that, then you're likely in the right place.
Yeah,
If they look like you like you're crazy, or if it seems like they're just too busy or too impatient to work with you, then maybe you're not in the right place, because
right.
the answer is this, like everything else, is learnable.
What is the typical population you see in EP? Like, I picture a lot of just old people.
I think that's a really great question because there is cradle to grave EP services. There are people that very specifically specialize in pediatric electrophysiology. People can be born with arrhythmia problems. People can be born with heart block problems, and that's a very specific specialty. It's small, but it exists. And then you can have teenagers that get palpitations, and maybe they have an SVT. I really think SVT is an interesting example because it's really a very sudden onset, sudden offset thing that's hard to catch. And I referred earlier to people that think they're starting to lose their minds because they just kind of get weak and dizzy and get the vapors. And the answer is no, it's their arrhythmia clicking on and on. So there is that of people that live with it for years. And then there's an aging population of things that tend to come with it. So as we get coronary artery disease and get areas of infarction, you can get ventricular tachycardia. There are many things we can do a whole nother segment on atrial fibrillation, as well as the options for ablation of atrial fibrillation that are available to not all but many. And then the heart failure population, which is ever growing both in devices and arrhythmias, so that there are many opportunities, and it's a really dynamic thing. I think that there's this amazing piece of hunting for an arrhythmia, of finding it. And there, I talked about wires that you put in, but there are also these really amazing 3D mapping systems where you can map out the heart, where you can see the inside of it with your map, but you can also map the electricity flowing through. So just these amazing stories that really can change somebody's life. I mean, it's the difference between somebody feeling healthy or feeling like, Oh no, I get weak and dizzy and pass out and nobody knows why. And I'm afraid because I think that means I'm going to die. People go through a real range of emotions, very justifiably, a real range of emotions when it comes to that. And I'm very satisfied by the number of people that I've fixed with a glass of water. How many people are coming to me feeling really weak and dizzy and are amazingly just hypovolemic, or people who feel weak and dizzy and whoever is treating their heart failure did the job of maximizing their heart failure medications just as they should, but it was just a little too much that was making them feel miserable.
Mm,
Sometimes if you just back off a little bit, people feel amazing, and that becomes clinical judgment to be done with a team. So
yeah.
there's so many there's so many impactful things that you can find and affect. So I found it very satisfying, and I still love it.
So it sounds like when you're in EP, you probably work very closely with a cardiologist.
Yeah, so I had an EP team who I love very dearly, and just a lot of smart, thoughtful people. And I think, like any PA practice, I really am in favor of practice being decided at the practice level. And the answer is that the physicians for whom were my colleagues and I had a great trust and a relationship, meaning that I knew my limitations and they were always happy to talk. There are times that I saw patients and I didn't have a conversation with a physician. I just saw that patient. Or if there was something to mention, we mentioned later. But there were also many things that I did go to them as well because they are smart, thoughtful people that have spent their lives in this specialty. So it's not an ego thing. And what happens is it's hard to define where that line is because it's different for every person.
You've said a lot about what you love about the specialty, and it sounds very interesting and exciting. But what do you think are things that people might dislike or find challenging about the specialty?
So I think if you find that you're a person that really likes looking at EKGs versus somebody who's afraid of them, if you're somebody who just naturally likes tech and looking at it, if you're somebody who doesn't need to have the right answer right away, but at the same time isn't letting the question go, because many patients just, it's okay that you don't know the answer. Many people haven't known it before you came along. That's why they found a specialist. But the difference between you and the people that have come before is that you're not letting the question going away. You're going to keep thinking about it. You keep looking at it. You're going to talk to your very smart, thoughtful friends around you. So I think that for the people who naturally are listening to this and say, that's amazing, well, then look at it. For the people who are looking at it and say, it doesn't sound like me, then you're probably right because there's some reasonable research out there exploring different personality types and their attraction to medical and surgical specialties. So sometimes the things that make it good or bad are just you. There's this wonderful Einstein quote that a fish would think it was a failure if judged by its ability to climb a tree. So as long as you're not the fish trying to climb a tree, that's fine. And if you wake up one day and realize, oh my goodness, I think I might be the fish trying to climb a tree, that's okay. Congratulate yourself for the insight and find some water.
We talked about being prepared or how to get into this specialty and things that resources you can look at. Can we talk a little bit more about those resources? What was that organization that you mentioned earlier?
Yeah, I highly recommend the Heart Rhythm Society. They are amazing at education through their conferences and through their online materials. But here's a tip for anybody finding themselves in any specialty is start reading the specialty journal. And you might say, well, why would I do that? Because they're talking about what's new, but I want to get a baseline feel. However, when you really look at how an article is structured, in the introduction, they frequently talk about what is the baseline level of knowledge in that area. That introduction and the discussion at the end, there's a lot to it. So I think that works in any specialty to read the scholars because the scholars do a great job of telling the story. Another thing that I like is that the companies who make the devices are very aware that their devices have a learning curve. So there is a fair amount of education that can happen through the companies so that you can become more familiar with their device and more comfortable. In addition, there's a lot of education that happens for electrophysiology fellows, both in person where you can go, but find the textbooks that they're reading. No reason you can't pop open that textbook, because I do believe that PAs and NPs can be experts in this field. Matter of fact, our patients need more people to be experts in this field because I think it's an underserved population.
For those people who are still in school or about to go into school, besides a specific EP rotation, what other rotations would you advise people to try to get?
The good news is I also come at it from a perspective of PA educator, which I am full time these days. And I can tell any PA student that's watching this now or in the future that right now there are 7 required rotations for every PA, and the meat of what you need to be a great PA exists in those rotations. So I don't want you to for a second to think, if I don't get this perfect experience, my career is done forever. I just want to just assure you. However, I think it may be too specific to jump into an EP rotation right away. I would advise you to find a general cardiology rotation. It's not helpful for you or your patients to be so hyper focused that you don't know understand other parts of cardiology.
So that leads easily into the next question. Do you think that this is a specialty that new grads should consider, or do you really feel like they need to work for a certain time in family practice or general internal medicine?
So here is where I will be controversial and I will acknowledge that thoughtful people can disagree. I think that there is no specialty that a new grad can't go to and embrace and dive into.
Mm.
If you find this is a thing you love, why should you wait to love it in 3 years?
Any other parting words or thoughts that you have for people out there?
I'm really grateful for the invitation to talk with you and to reach a broader audience. And I really am excited about the PA community at this stage right now. There's so much happening in healthcare. There's a growth in our profession, and there are so many things that we are doing and things we could be doing that we hadn't imagined.
I feel the same way as I do more and more of these videos and talk to people and see what PAs and NPs are out there doing. I feel that the future is bright for APPs for both professions. And I encourage people to figure out what it is that really gets them excited in medicine and to follow that path. So thank you so much, Dave, for sharing with us today and for giving us your time.
Thank you.
I'm curious what you thought of electrophysiology. Let me know down below in the comment section. If you want to learn about what it's like working in regular cardiology or in other specialties, you can watch these videos here or check out the medical specialties playlist on my main channel page. Thanks for joining me. Don't forget to subscribe, and I'll see you next time on Medicine Couch. Bye.